Hello, I am Shafi Rahman, and today we are going to discuss about the nephritic syndrome. Now, the hallmark feature of the nephritic syndrome is the glomerular inflammation and bleeding. If we compare it with the nephrotic syndrome, so the difference between nephrotic syndrome and nephritic syndrome is the degree of the proteinuria. So, in nephritic syndrome, the protein leakage is less than 3.5 gram per day as compared to nephrotic syndrome, in which there is greater than 3.5 gram per day leakage of proteins. The second thing which is worth mentioning in the nephritic syndrome is the oliguria and azotemia, as evident that it's a renal disorder. So of course there will be less flow of the urine in the tubules, and definitely there will be the buildup of that nitrogenous waste product in the blood. Then there is a salt retention with periorbital edema and hypertension. So hypertension is usually classically associated with nephritic syndrome, but it doesn't mean that in nephrotic syndrome it can't happen. In nephrotic syndrome, hypertension can also occur, but classically we just associate hypertension with nephritic syndrome. And then as glomerulus is having inflamed process going on, inflammation process going on, and there is bleeding, so what will happen that the red blood cells will leak in the tubules. Now when they will leak in the tubules, so they will form the shapes of the tubules, and hence RBC casts will be found in the urine, because they are the red blood cells. When they are collecting in the tubules due to bleeding in the glomerulus, what will happen? They are assuming the shape of the tubules. They are molded into the shape of the tubules, and hence the cast formation will occur in the shape of the tubules, and there will be the dysmorphic RBCs or RBC casts in the urine. So these are some of the hallmark features of the nephritic syndrome. Now the prototypical disease, or you can say that on biopsy in nephritic syndrome, we are finding that hypercellular inflamed glomerulus. So when we are taking the biopsy of the sample, we are just seeing the hypercellular inflamed glomerulus because the process of inflammation is going on, and there are immune complexes depositions in that glomerulus, and which ultimately activates the complement system. Now immune complexes means that when antigens, antibodies join together and they form complexes, and those complexes get deposits in the glomerulus. So what will happen that when they will deposit in the glomerulus, they will activate the complement, and one of the complement factor is C5a, which attracts the neutrophils and which hence mediate the process of inflammation. So in this way, on biopsy of the nephritic syndrome, generally we are finding hypercellular inflamed glomerulus, and also there is bleeding as well. So nephritic syndrome is not an isolated disease. It contains several subtypes which are included in the nephritic syndrome, and the first of this which is worth mentioning and worth discussing is the post-streptococcal glomerulonephritis. It's a prototype disease of the nephritic syndrome. The post-streptococcal glomerulonephritis comes under the umbrella of the nephritic syndrome, and it actually arises after group A beta hemolytic streptococcus infection of skin or pharynx. Now it's like an infection of skin or pharynx with the group A beta hemolytic streptococci, and during the resolution of that infection, immune complexes can form and can deposit in the glomerulus, and hence can initiate the process of the nephritic syndrome. So basically what happens with the nephrogenic strains of group A beta hemolytic streptococci, that they carry M protein virulence factor within them. So M protein is the stimulus through which antibodies can be generated and hence complexes can be formed. But the point to note here is that This post-streptococcal glomerulonephritis can also occur with other non-strep organisms as well. So most commonly it is called post-streptococcal glomerulonephritis, can be called post-infectious glomerulonephritis. So during the resolution of any infection, this pattern of nephritic syndrome can happen. So what will happen that during the resolution of the infection, 2 to 3 weeks after the infection, what will happen that patient suddenly develops hematuria, cola-colored urine, oliguria, hypertension, periorbital edema, and usually it's most common with children. So, but it doesn't mean that in adults it doesn't occur. So, the point to understand the nephritic syndrome subtype post-streptococcal glomerulonephritis is that infection occurs of the skin or pharynx with group A beta hemolytic streptococci, for example, with the presence of M protein. Immune complexes will form, and those immune complexes will get deposited in the glomerulus and hence can initiate the process of the nephritic syndrome, and proteinuria will start occurring. So when we biopsy such lesions, so what will happen that we will see the hypercellular inflamed glomerulus on H&E stain, as was expected in the nephritic syndrome, and it's mediated by immune complex deposition, and the pattern will be the granular immunofluorescence on immunofluorescence. So there are two different types of pattern of immunofluorescence which we will discuss shortly. One is the linear immunofluorescence and the other is the granular immunofluorescence. Immunofluorescence basically shows the smooth continuous staining with no gaps on immunofluorescence. It signifies surface-bound antigens and most commonly found in the Goodpasture syndrome, which we will discuss shortly. In contrast, the granular immunofluorescence is basically, we can say that it's a tripled, lumpy, bumpy staining of the antibodies, and it signifies the position of the immune complexes, and it's certainly not linear like those found in the Goodpasture syndrome. So, in post-streptococcal glomerulonephritis, we are seeing the granular immunofluorescence on immunofluorescence. And on electron microscopy, we will see the subepithelial humps, and subepithelial humps is basically the collection of these immune complexes which are initially deposited in the subepithelial area, but then they gradually migrate towards the subepithelial sides, and there they get deposited and eventually it gets lost in the Bowman space. So treatment is usually supportive and children rarely progresses to renal failure, but in some adults it can progress to the lethal or rapidly progressive glomerulonephritis, and which can be proved fatal. Now, what is RPGN or rapidly progressive glomerulonephritis? So it's basically nephritic syndrome, comes under the umbrella of the nephritic syndrome, that progresses to renal failure in weeks to months, and eventually the patients either have to go towards the dialysis or they have to go for the transplant. So what it is characterized, RPGN is characterized by the presence of crescents in the Bowman space on H&E staining, and the composition of that crescents is fibrin plus macrophages. So what RPGN is? RPGN is basically nephritic syndrome that can progress towards the renal failure very shortly in weeks and months. And what it is, a hallmark feature is the formation of the crescents in the Bowman space, and the crescents are composed of fibrin and macrophages. So now we will just discuss the immunofluorescence, three different types of immunofluorescence pattern, and which we have to understand for the purposes of understanding of the nephritic syndrome. So the first pattern of the immunofluorescence is the linear, or it is also called anti-basement membrane antibody. So the classical disease in which the linear immunofluorescence pattern is Goodpasture syndrome. So what happens that antibody is formed against the collagen in the glomerular and alveolar basement membrane. So the point to note here is the antigens are present in the basement membrane, and antibody is coming from outside and it's getting deposited over that antigen. There are no immune complexes. So the hallmark features of the Goodpasture syndrome is the involvement of lung as well as simultaneously the kidney is involved. So hematuria plus hemoptysis is classically Goodpasture syndrome. So in Goodpasture syndrome, we are seeing the linear immunofluorescence pattern. Now the second pattern is the granular immunofluorescence pattern, in which there is the formation of the immune complexes deposits occur. So as I've discussed previously, that it's a triple lumpy bumpy staining, in contrast to the linear immunofluorescence, which is straight, smooth, continuous staining with no gaps. So the disease in which it is occurring in the granular immunofluorescence, first we have discussed post-streptococcal glomerulonephritis, and the second one is the diffuse proliferative glomerulonephritis. So in these two diseases, we are seeing the pattern of the granular immunofluorescence. So diffuse proliferative glomerulonephritis is due to diffuse antigen antibody complex deposition, usually in the subendothelial area, and it's the most common cause of renal failure in systemic lupus erythematosus. So the granular immunofluorescence is found in post-streptococcal glomerulonephritis and diffuse proliferative glomerulonephritis, which is commonly found in SLE. Then the third type is the negative immunofluorescence, in which there is no pattern of immunofluorescence, and it is classically it is called pauci-immune. Pauci-immune means that there is no staining pattern found on the immunofluorescence. So the classical diseases in which it can occur is Wegener granulomatosis, microscopic polyangiitis, and Church-Strauss syndrome. So I'm hopeful that you all are getting this point, that in these three diseases there is no immunofluorescence, and it is also called pauci-immune. Pauci-immune means that there is negative immunofluorescence. Now the point to ponder upon is that Wegener granulomatosis, it's also involving lungs, it's also involving kidneys. So how you will differentiate Wegener granulomatosis with the Goodpasture syndrome, which is also involving lungs and kidneys? So in Wegener's, what is most common is that there is presence of nasal symptoms as well, like for example sinusitis or nasal polyps or anything along these lines. So to differentiate clinically between Wegener granulomatosis and Goodpasture syndrome, you have to see the presence of the nasal symptoms. And then there is another antibody which is called C-ANCA. It is classically associated with Wegener granulomatosis, and it is not associated with the Goodpasture syndrome. So the differentiating point between Wegener granulomatosis and Goodpasture syndrome, first thing first, that Goodpasture syndrome is having linear immunofluorescence and Wegener is having pauci-immune or negative immunofluorescence. Both are involving lungs and kidneys, but sinusitis or nasal symptoms are only found in the Wegener's, and then the Wegener is also associated with the C-ANCA antibodies. Then microscopic polyangiitis and Church-Strauss syndrome. These are also having pauci-immune pattern, and they are both associated with another antibody which is called P-ANCA. So how you will differentiate between microscopic polyangiitis and Church-Strauss syndrome is presence of granulomatosis inflammation, granuloma formation, eosinophilia, and asthma. These are three classical patterns which are seen in the Church-Strauss syndrome, but which are not in microscopic polyangiitis. So in a scenario in which there is negative immunofluorescence in P-ANCA, so the two differentials which have to be in our mind is Church-Strauss syndrome and microscopic polyangiitis. And how you will differentiate between these two is the presence of granuloma, eosinophils, and asthma in Church-Strauss syndrome, which is not found in the microscopic polyangiitis. Now the other disease worth mentioning is the IgA nephropathy, and it's simply the IgA antibody form immune complexes, and it's get deposited in the mesenterium of the glomerulus. So mesenterium of the glomerulus, when contain IgA immune complexes, it is called IgA nephropathy, It is the most common nephropathy worldwide. It usually presents during childhood, and the hallmark feature is episodic gross or macroscopic hematuria. So, if we are finding episodic gross or macroscopic hematuria in a scenario or in real life, we can have that differential in our minds. So, episodic gross or macroscopic hematuria with RBC cast usually following the mucosal infections, and usually mucosal infections generate that IgA antibody. So, IgA immune complexes in the mesangium, episodic gross and macroscopic hematuria with RBC casts. It is called IgA nephropathy. And IgA immune complex deposition in the mesangium will again show the granular immunofluorescence, as discussed previously, that what granular immunofluorescence is as compared to the linear immunofluorescence. And it can also progress towards the renal failure. Now, the last subtype is the Alport syndrome, but it's usually a genetic disorder. It's not the formation of immune complexes or complement formation. It's simply a genetic disorder in which there is X-linked inherited defect in the type 4 collagen. So that's why there is um, thinning and splitting of the glomerular basement membrane, and it can present as isolated hematuria, sensory hearing loss, and ocular disturbances because of presence of type 4 collagen in these areas. So with this, we conclude our lecture of nephritic syndrome.